So Sagar, thanks so much for having me. It's a pleasure to be here at Winship, at Emory. I remember I was here 15 years ago to talk about thalidomide. The talk today is on evolution of myeloma, and it's almost like a pun because I would like to spend the first half of the talk on the real evolution, which is how we studied monoclonal gammopathy of undetermined significance, which is what starts myeloma and what we have learned about it. And then the second half on the evolution of the disease definition, which is separate, which is what we call myeloma and how the term came about and how we are changing what it means to be called multiple myeloma, which is a different type of evolution. I have no conflicts of interest to disclose. In terms of when you're talking monoclonal gammopathy of undetermined significance or disease evolution, it's impossible to get anywhere without starting with Bob Kyle. Bob Kyle has been my mentor at Mayo Clinic for many decades now, and he coined the term monoclonal gammopathy of undetermined significance in 1976. And at that time, he coined it based on the finding that there are patients with monoclonal proteins who have clonal plasma cells in the bone marrow, but they have no evidence of myeloma or organ damage. And he said it was undetermined mainly because he didn't know whether or not the patient will stay benign or whether they will eventually get multiple myeloma. So it was only, at the time there was a debate with Jan Waldenstrom, who called these benign monoclonal gammopathies, and Bob wanted to say, no, these are not benign, because a year or two later, some of them get myeloma. 5 years later, they get myeloma. 10 years later, some of them get myeloma. I'd rather not call them benign, but I'll call it monoclonal gammopathy of undetermined significance. At that time, Bob did realize that monoclonal gammopathy of undetermined significance is not the only problem with it, is not simply that it becomes myeloma, but that it does cause other things. He knew that. So by using the term MGUS, or monoclonal gammopathy of undetermined significance, he was not denying that MGUS can also cause Waldenstrom's, it can also cause amyloidosis, or other non-malignant conditions like cryoglobulinemia and so on. But Bob set out to study monoclonal gammopathy of undetermined significance, and I would say he studied it using a population-based work that's from southeastern Minnesota and Olmsted County like none other can do. Bob's first paper in the New England Journal was 1965, the year I was born. His next New England Journal paper, first author, 25 New England Journal papers later, is going to be next year or this year. And he's aged almost 90. Remarkable body of work. So a lot of what I'm going to say is really credit to Bob Kyle and the stuff that he has found. So how common is monoclonal gammopathy of undetermined significance? This comes from a study that Bob Kyle did where he said, if I'm going to find out how common MGUS is, I basically have to take a well-defined population and test everybody. So Olmsted County, Minnesota, which is where Rochester is located, has 27,000 people who are age over 50. And he studied all of them virtually. Checked monoclonal protein levels on all of them, and he found that 3% of the general population has a monoclonal gammopathy of undetermined significance, age 50 and higher. He also found that men have a higher risk of monoclonal gammopathy of undetermined significance than women. He found that the prevalence of MGUS increased, so that if you're 50 to 60, there's a 1 to 2% chance of having an MGUS, but as you get older, over the age of 70, 5% of the general population has a monoclonal gammopathy of undetermined significance. Later on, more recently, we have a new assay called the free light chain assay, which is able to detect monoclonal light chains only without intact immunoglobulin. And if you look at free light chains, there is an extra 1% of the general population who has a light chain MGUS. That is, they have a monoclonal protein, but it's not heavy and light chains. It's not an intact immunoglobulin, but just the light chain alone. So about 4% of the general population over the age of 50 in the United States has a monoclonal gammopathy of undetermined significance. And here you can see the red line is MGUS, light chain and heavy chain together, and this is the light chain MGUS, which is about 1% of the population. One of the most remarkable things about myeloma is that the prevalence varies dramatically by race. If you take many conditions where we say that there is a racial disparity, say whites have a greater risk of this or that, or blacks have a greater risk of this or that, usually you're talking about 10% higher risk, 20% higher risk, 30% higher risk. But in MGUS and myeloma, you're talking 100%, 200% higher risk of MGUS and myeloma in blacks compared with whites. That remarkable type of racial disparity is unheard of in cancer, except maybe in prostate cancer. And this slide shows you that the age-specific incidence, the red is white, blue is black, and you can see that at every age there is a higher risk of multiple myeloma in blacks compared with whites. And if you look at this is the relative risk here. There's a twofold higher risk of myeloma in blacks compared with whites. And in the younger age group, like if you go to age 40, if you take 40-year-olds in the United States, the risk of multiple myeloma in blacks is like 3-4 times higher. That's remarkably high. And the question for me and other colleagues that I've worked with is, why is this? And what is the mechanism for the higher risk of multiple myeloma in blacks compared with whites? And what we're finding is that the increased risk of myeloma in blacks is related to the increased prevalence of MGUS, the precursor lesion, and that the transition from MGUS to myeloma occurs at the same speed with blacks and whites. But the prevalence of the precursor lesion is for some reason much higher in blacks compared with whites. I'll show you some of the studies that led to that conclusion. These are studies I did with Ola Landgren at the NCI at the time. We both collaborated on these studies. The first one was a study of the NHANES. We used the NHANES, the National Health Nutrition Examination Survey, samples the entire United States by a stratified random sampling. So when you get data from NHANES, it reflects the whole US population. And what we found was and it's oversampled for African Americans and Hispanics so that you get a pretty good estimate of prevalence. And this study shows you, this is whites versus blacks and Mexican Americans. Blacks have a markedly higher risk or higher prevalence of monoclonal gammopathy of undetermined significance compared with whites at all age groups. It's there from 50 onwards. And this was in a study of 12,482 individuals. If we then did a study which is just published in Blood Cancer Journal this week, which looked at children aged 10 to 18 as well as adults 18 to 49, so younger people. And the hypothesis was that that MGUS actually starts earlier in blacks compared with whites. And if you look here, at age 40, you can see that the blacks already have a 3.26 per prevalence. 3.2% of African Americans have a monoclonal gammopathy of undetermined significance in the age 40 to 49. That's remarkable. And that's compared to 0.53 in whites. And if you look at younger age groups, even 30 to 39, we are starting to get about 1% of African Americans, 30 to 39, already have an MGUS. So it tells us MGUS starts earlier in African Americans. The disparity is apparent even earlier, and even as young as 20 to 29, you're starting to see there's no one in the white population who had an MGUS age 20 to 29, and we had people, 0.26% of African Americans already have an MGUS at that age group. We then asked, we have asked the question if there's an increased risk of MGUS in African Americans, is this risk there in Africa as well? Or is this something that is an environmental thing that happens in the United States based on the locations where population centers are? And so this study was done in Ghana. The study was initially for prostate cancer, but we managed to get 1,000 samples from Ghana, Ola and myself, and we tested those, and we found that there is a higher risk when we compared the prevalence of Ghanaians to Olmsted County, Minnesota. There is a 2 to 3-fold higher risk of MGUS in Ghana compared with the white population of Olmsted County. So that the increased risk of MGUS in African Americans is present even in blacks from Africa. But it still could be that there are social environmental factors, because maybe the socioeconomic status is in some way not adjusted for. So the next study we did was in a southern cohort. This is called the poor patient study. And it's 1,000 women, 1,000 white women and 1,000 African-American women in the South who are of similar socioeconomic status. They're all poor, they're all coming from the same place, and then we said, okay, we are adjusting for all these other factors. Let's see whether the risk is higher. And you can see black race, twofold higher risk of MGUS in women of the same socioeconomic status compared to white women. In that study, we also found that obesity was a risk factor for MGUS. One other tidbit that we found out is that there are many types of myeloma, as you know. There are trisomies, there are translocations, but for whatever reason, outcome of myeloma in blacks is better than whites. So this was seen in the ECOG trial of RD versus RD, where we noticed that non-white survival probability was twofold better compared to the white survival probability, which tells us that the type of myeloma that occurs in African Americans is probably more a low-risk type. It's the trisomic variety probably, and that's what we've found from preliminary data, and this is what we are investigating, that the excess risk is almost fully captured probably by trisomies, and they respond well to lenalidomide. This study also showed us that if you have actually good access to care, which is happening in a phase 3 trial, in a phase 3 trial, drugs are provided free of charge to all people, that outcomes are not only similar, but actually better in African Americans compared with whites. So a lot of the differences in outcome that you see in studies are due to access to medications, access to care, which there is a striking disparity. Now, race is not the only factor that dramatically affects the prevalence of MGUS, but family history also does. And in many studies that we have done, Ola has done, and others have done, we have found that there is a 2 to 3-fold higher risk of MGUS in first-degree relatives of either myeloma or MGUS probands. And this study shows you the observed versus expected. This is what Olmsted County, Minnesota looks like. This is what first-degree relatives prevalence looks like, about a 3-fold higher risk of MGUS in first-degree relatives. And this, again, asks us the question, there's a lot of genetic predisposition going on, whether it's based on race or based on family history. MGUS may also be related to environmental factors. So genetics is not the only thing. If you look at survivors of, say, 9/11, the firefighters, they have a higher risk of myeloma. And so we looked, in the past, people have found that there's a higher risk of myeloma in people exposed to certain chemicals. This slide I made mainly for you to look at how many different factors we looked for. These are all various kinds of pesticides, about 50 different kinds of pesticides that we looked at in agricultural health study. This was a study, again, we did with Ola Landgren. 678 men from agricultural health study, where detailed information on what pesticide exposure, how much was already abstracted and available, and then compared to the Olmsted County population. And what we found was 3 types of pesticides had a higher risk of being associated with MGUS, and you can check out the paper. I mean, there's a lot of work on other chemicals, benzene, petrochemicals that are related to MGUS as well. So it's not just genetic predisposition from a racial or a familial standpoint, but also environmental exposure together causes MGUS. One other question that comes up oftentimes is, if myeloma arises from MGUS, is it possible to get de novo myeloma, or is a patient with myeloma always having a precursor MGUS lesion? And this is a very interesting problem to study. Because when you see a patient with myeloma, you don't have samples from 10 years ago on that patient. That patient was never checked for MGUS, so it's impossible to find out if they had an MGUS 10 years before. So to address this problem, we took advantage of the PLCO study, the prostate, lung, colon, ovarian study. This, again, paper that I did with Ola Landgren, where 150,000 people are randomized to screening versus no screening. The screening cohort had blood done every single year for many, many years, 10, 15 years. And it so happened that about 70 people in the PLCO study developed myeloma, and we had samples on them going back 10 years. And we were able to show that in known myeloma patients, if you check their samples every year preceding, 100% of them had prior MGUS that you could detect many years before the diagnosis of myeloma. That answers one question. You know, all myeloma is preceded by MGUS. But it also tells us that there's potential for screening, there's potential for intervening, the potential for interrupting the progression of myeloma if we were able to catch these people in time, and if we had an intervention that was benign enough that you could use to intervene. How common does MGUS become myeloma? Well, the risk has been established by Bob. This is in 1,384 patients. The paper was in 2002 in the New England Journal of Medicine. It established that 1% of patients with MGUS each year go on to get multiple myeloma. And you can see here, look at this curve, the first full progression curve. It's 25% at 25 years, 20% at 20 years. It's like clockwork. 1% each year go on to get multiple myeloma. Bob did this study in 2002. Wait for an update, hopefully soon, with another 15 years of follow-up in terms of what it happens. Another point from this particular study was, for those of you who are statisticians and who are interested in population-based sciences, you can address important biologic questions by doing a population-based study. So if there are two models of cancer progression, one is that you get cancer because there's a random event that happens. Every year something happens, it's chance, a mistake happens by chance, and then you get the event. If that's the case, this is how the curve looks like, where there's a fixed risk. If you've had MGUS for 5 years, then the next year you have a 1% risk. If you've had MGUS for 20 years, the next year you still have only 1% risk. It's not like you have a higher risk because now you've had so many years of MGUS. The second one is a cumulative damage model, which is more like smoking. The more you smoke, the longer you smoke, and how much you smoke determines the risk of lung cancer. That's a cumulative damage model, which will have a different shape. So MGUS to myeloma transition from these studies, it's apparent to us is a random event or a one double hit random event model rather than a cumulative damage model. And it's more like, it's the Vegas or the gambler's fallacy doesn't operate here. That if you have a slot machine and you lose 10 times, you think, oh, I'm going to win the next time more. No, the odds are exactly the same. That's how this is. MGUS to myeloma progression is exactly the same regardless of how long you've had it. The type of progression varies depending on the type of MGUS. We now classify MGUS into 3 types. IgM MGUS, which has a risk of progression mainly to Waldenstrom macroglobulinemia. IgG, IgA, all of those are called non-IgM MGUS. That has a risk of progression to multiple myeloma. And then you have light chain MGUS, which has a risk of progression to light chain myeloma. So depending on the type of MGUS, the type of progression varies. All of these types of MGUSs, though, can cause AL amyloidosis and related plasma cell disorders. As I mentioned initially, myeloma is not the only problem with MGUS. If myeloma was the only problem with MGUS, well, that's only 1% each year. It would be a simple thing. But there are bigger problems with MGUS, and you have to understand the transition and how this happens. MGUS to myeloma transition is more or less similar to the colon polyp to colon cancer thing. The first step is you have the polyp become, the normal colon cell becoming a polyp. And the second thing is the polyp becoming cancer. So it's who's getting my MGUS and why does MGUS become myeloma? It's really very difficult for us to understand, but this is the best estimate of, I think, of what is happening. There are normal plasma cells, and some random event happens that causes the first hit. And that could be either 50% of MGUSs get a trisomy, and a trisomy establishes the MGUS clone. The other 50%, they get an immunoglobulin heavy chain translocation. One of the 5, there's 1114, 414, 1416, 1420, and 614. They're all partners with the 14q32, which is the immunoglobulin heavy chain locus, and oncogene moves there, and you get the establishment of the clone. So 50% of MGUS is established by the occurrence of trisomies, and the other 50% of MGUS is established probably by the occurrence of immunoglobulin heavy chain translocations. Then the MGUS to myeloma transition is a second random event, and that one, most likely culprits are MYC translocations in about half of them, and RAS mutations in about half of them. At the same time, there's induction of angiogenesis, there's secondary cytogenetic events that happen, and then you get the myeloma progression. And myeloma subsequently, over the course of some 5 years or so, transforms into a more aggressive, vicious type of myeloma, secondary plasma cell leukemia, and so on. This is our best understanding of the progression. The risk factors for progression, there are 3 main risk factors. One is how much monoclonal protein we have. So this slide shows you the bigger the monoclonal protein size, the greater the risk of progression. So a 2-gram M spike has a much higher risk of progression than a 0.5-gram M spike. The type of M spike also is the second risk factor. So IgM has a higher risk of progression than IgA, and IgA has a higher risk of progression than IgG. And then the third risk factor is the free light chain ratio. The free light chain ratio is a ratio of the kappa to lambda free light chains that we have. And you can see here, those patients, about a third of MGUS patients have an abnormal light chain ratio, and they have a much higher risk of progression than the remaining 2/3 who have a normal free light chain ratio. So if you put these 3 factors together, it establishes a simple risk model. That this was something that we published in 2005, again on 1,148 patients, where you take patients with MGUS and you can classify them based on the size of the M spike, the type of the M spike, and the free light chain ratio. If you have a small M spike, less than 1.5, a normal free light chain ratio, and it's IgG type, the risk of progression is fairly low, and that's shown in this curve. Whereas if you have a bigger M spike, which is not IgG, and an abnormal light chain ratio, then the risk of progression goes on. So depending on 0, 1, 2, or 3 risk factors, you have a establishment of risk of progression. And if you look at the actual numbers, you have to look at this last column here, the risk of progression adjusting for other causes of death. You know, if you have, if a 65-year-old has an MGUS, the 20-year probability of progression is 20%, provided they live 20 years. But oftentimes other things are also going on. There's other cancers that can happen, mortality from other non-malignant diseases, cardiac diseases happen, so that if you adjust for competing causes of death, this is the number that I would encourage clinicians to look at. And this is important because what it shows you is that half the MGUSs that we deal with are low risk. They're less than 1.5 small MGUSs that are IgG, that are normal light chain ratio. And they have a lifetime probability of only 2%. It's not 1% per year, but over a whole lifetime, there's only a 2% chance that people with low-risk MGUS will ever get myeloma. That then has implications for how we manage these patients. Do we really need to check them every year? Do we really need a bone marrow? And so on. On the other hand, patients with high risk multiple risk factors, a quarter of them get myeloma realistically. And so that's important to keep in mind as well. So that comes down to management of MGUS. And this was a proposal that I made, and then Bob Kyle took a while to persuade him that we don't need to follow all MGUS patients forever. And he agreed, and then the International Myeloma Working Group also agreed. So that now what we're saying is low risk, uncomplicated MGUS, which will be half of all the MGUSs that we deal with, half of all the MGUSs that people call you about from internal medicine, refer to you. These patients, we are saying, number one, you don't need a bone marrow. If they look like an MGUS, smell like an MGUS, then it's probably an MGUS. The Italians have taken all these patients and done a bone marrow on all of them, and they found that you never find anything that you didn't expect. You don't find 25% plasma cells. It's always less than 10, and you don't need to do a bone marrow. You don't need a bone survey on these patients. They almost never have bone lesions. And that also the Italians did a bone survey on all of them and found virtually no use to those tests. If you have a doubt, of course, if you have a small MGUS but the patient has back pain or some other symptom, by all means go for a bone marrow and bone survey. But if it's low risk, uncomplicated, omit the bone marrow, omit the bone survey. Check them only one time 6 months later to make sure that you haven't caught a rapidly rising protein. And if that's stable, then they don't need to be followed at all. Then you can just follow up only if they get symptoms. And that saves a lot of money. It's like part of choosing wisely. It's also effective care because the patients are not constantly worrying about, am I going to get myeloma? They're not. I mean, it's very unlikely. All other MGUS patients, though, need a baseline bone marrow, baseline bone survey, and then you check them in 6 months and then once a year thereafter. As I mentioned to you before, the MGUS causes all kinds of other problems besides myeloma, and so when you follow a patient with MGUS, they really need to be taken care of for all kinds of other things. So for example, fractures are much higher in MGUS patients than in normal patients who don't have MGUS. And that's shown here. There's a 6.3-fold higher risk of vertebral fractures in MGUS patients that is not related to myeloma. It's just they still are MGUS, but they have a higher risk of fractures. So maybe they need once-a-year bisphosphonate or some consideration like that. I would say that the problems that MGUS can cause can be divided into 3 groups. One is the true malignancy risk, that is becoming a solitary plasmacytoma or multiple myeloma Waldenstrom's. That's shown here. The second thing is that unlike other pre-malignant lesions, let's say carcinoma in situ of the breast or prostate cancer, carcinoma in situ of the prostate, or colon polyp, these benign clones, they're not sitting there and doing nothing. They are secreting protein, and the protein is not like PSA, a benign innocuous protein. The protein is actually an antibody, and the antibody can cause problems. So the paraprotein that is secreted by clonal plasma cells, they're non-malignant, but yet can be dangerous. In some of these patients, it can cause amyloidosis. In some of these patients, it can cause light chain deposition disease. In some of them, it can cause cryoglobulinemia, and so on. There are also many other diseases that these paraproteins can cause. It can be the cause of neuropathy, cause of glomerulonephritis, cause of many skin disorders. And the way to think of these two is these are diseases which are purely caused by plasma cell disorders. So if you have AL amyloidosis, it's always caused by immunoglobulin light chain. These are disease associations. So that means many, many things can cause neuropathy, of which MGUS is one. Many things can cause glomerulonephritis, of which MGUS is one. And so the way we approach these patients when we work them up is different. We looked at a study in Olmsted where we looked at all patients with all diagnosis codes, 16,000 of them. And this spreadsheet's available in terms of for every possible condition, what is the incidence in MGUS versus incidence in patients who don't have MGUS. And this is based on population-based studies, so it's everybody was screened for it, so it's got no bias of why you checked for the MGUS in the first place. And out of the 16,000 diagnosis codes, only like 5 or 10 of them are real associations with MGUS. Whereas if you go to the literature, about 135 different diseases have been attributed as being due to MGUS. Most of them are, though, coincidental. They're really not really associated. They're just coincidental. Because MGUS is so common, 5% of people with back pain will have MGUS, 5% of people with a nail disorder will have MGUS, and 5% of anything will have MGUS, because that's how common the prevalence is. And so many reported associations are actually false, and only a few of them are real. One other point that we try to make to people is the risk of progression is much lower than the actual risk of dying from other causes, so that when these patients with MGUS come for follow-up, we emphasize that they need to be followed for regular things like anyone else. Another study that we did at Mayo was when we do follow these patients with MGUS and we are looking for myeloma year after year after year, how good are we? And this leads to my second half of the talk, which is on evolution of the disease definition. It turns out that by following patients with MGUS, we never really catch the myeloma in time. Because, let's see, if you have a patient with MGUS with a 1 gram M spike, they come back and you find that the M spike is now 1.5, and you do a bone survey, it's normal. You do high calcium, it's normal. You do renal failure, creatinine, it's normal. You reassure them that, well, you don't have myeloma and send them home. But if you really think about it, the only time you won't reassure them is if you actually find bone lesions, when you'll say you've got myeloma. So by following these patients, we are never catching them in time. We're basically just reassuring them falsely, and we were not able to actually act on them. That's because of the catch-22, which is that the disease definition is very much clinico-pathologic, and I'll go into that now. So unlike other diseases, other cancers, where the pathologist looks at the bone marrow biopsy and says you have follicular lymphoma or you have diffuse large B-cell lymphoma, in myeloma, the disease definition is clinico-pathologic. The pathologist tells you there's a clonal plasma cell disorder in the bone marrow. It's the clinician who says that the patient has hypercalcemia, renal failure, anemia, or bone lesions before calling them as multiple myeloma. So it's a clinico-pathologic definition where you need the lytic bone lesions to call it myeloma, where you need the CAS nephropathy to call it myeloma, but you don't want these things either. So you don't want patients to get bad bone lesions. You don't want patients to get acute renal failure, yet you are not willing to call them as myeloma until these things happen. So it just goes around. So this was something that to understand this, you have to almost go back to what is called smoldering myeloma and how this happened. Smoldering myeloma was a term coined by Bob Kyle in the 80s along with Phil Gripe, where he found patients who were in between MGUS and myeloma. These are patients who have a fairly big clone in the bone marrow, but they don't have hypercalcemia, renal failure, anemia, or bone lesion, so he called it smoldering myeloma. And the definition of the disease was that if you have crab features, then it's myeloma. If you don't have crab features, then it's MGUS or smoldering. And he split MGUS and smoldering based on the number of plasma cells. If you have less than 10% plasma cells, less than 3 gram M spike, that's MGUS. If you have 10% or more plasma cells or more than 3 grams M spike, that's smoldering. And that MGUS, smoldering, and myeloma, this was the continuum divided based on M spike size, bone marrow plasma cells, and crab or no crab. Why did they split hairs in terms of defining MGUS from smoldering? It's because the prevalence of the risk of progression of MGUS is 1% per year. But if you look at smoldering myeloma, the risk of progression is 10% per year. So you're going to be counseling patients quite differently if you see smoldering myeloma compared with if you saw them as MGUS. So you can see here 50% of patients with smoldering myeloma have a progression within 5 years. All these years, we used to watch these patients, and the disease definition of let's wait till crab features occur was okay because of the 3 reasons why we watched them in the first place. Number one was we didn't have good treatments. We knew some patients could go 10 years without progression, 15 years without progression. And so no point in treating patients who never are going to get the disease. And third was that there was really no proof that early therapy or early intervention benefits. So these 3 reasons prevented us from treating patients with smoldering myeloma or even trying to operationalize a disease definition that didn't require end organ damage. I would make the argument that all these 3 are not true anymore. Number one, as Sagar will attest, we have a number of good treatments for myeloma now. Many of them are fairly easy to give. Many of them have really outstanding outcomes, so that the fact that we don't have any good treatment, so don't bother treating smoldering, is no longer valid. Number 2, we do have data that early therapy could potentially save lives. This is a study that the Spanish did. And what they did was they took high-risk smoldering myeloma patients and randomized them to lenalidomide dexamethasone treatment versus observation. And this is the risk of progression in the control arm, which matched what we would expect. High-risk smoldering myeloma patients have a 25% per year risk of progression. So the median time to progression should be about 2 years. That's what this group had. Whereas the treatment group had a remarkably lower risk of progression. Overall survival was also better in the treatment group compared to the observation group. Now, there are many problems with this trial, and we have written about it. That's why the smoldering myeloma population is still watched, and Dr. Lunial is still, he's already he's the principal investigator of an ECOG trial that did lenalidomide versus observation, which we let continue even after these results came out because there are many problems with this trial. But one thing this trial told us was that it's very unlikely that you're going to harm patients by giving lenalidomide dex. It may be useless, but it could be potentially life-saving, and it's very unlikely that the curves are actually in reality flipped. So it gives us more willingness to say start treatment for patients with very high-risk smoldering. And the third is that although in the past we didn't know who's going to get myeloma and who's not going to get myeloma, that's also not true. We have a number of biomarkers that can tell us who is going to get myeloma very quickly. So if you look at the shape of this curve, this is very telling. The first 5 years, there's a 10% per year risk of progression. So 50% of patients with smoldering myeloma get myeloma within 5 years. If they didn't get myeloma in 5 years, then the next 5 years, the risk drops. It drops to about 3% per year. And if you've gone 10 years without progression, the risk drops even further. It becomes 1% per year. So the shape of the curve told us that smoldering myeloma is probably something where you could identify who are these people in this first 5 years. More importantly, who are these people who are going to progress in the first 2 years? And can we treat just those people? And the paradigm shift was that what we call smoldering myeloma is really not a in-between biologic stage where MGUS becomes smoldering and smoldering becomes myeloma. But rather, the term smoldering myeloma is the clinical definition where if you have 100 people with smoldering, half of them have MGUS. You just don't know who's who. Half of them have MGUS. half of them have myeloma. It's like it is not smoldering in the sense that there's a bunch of coal that is smoldering, but it's really half just cold coal, which is not burning, and the other half is burning. You just don't know who's who. And if you knew who's got myeloma, then you would be willing to treat. This was the paradigm shift, that this is not an in-between biologic stage, but rather a clinical definition which is mixed up of people who have myeloma and who don't. So can we identify these people with myeloma from the people with MGUS? Yes, we can. At least we are starting to. And the first three parameters that we have found are the percentage of bone marrow plasma cells. And this started with simple questions. You go to ASH and you give a talk and you say smoldering myeloma is more than 10% plasma cells and more than 3 grams M spike. The first question from the audience is, what if I have 80% plasma cells? Is that still smoldering myeloma? I don't have crab features. And that made us think hard. And we went back to our database and looked at people who had more than 60% plasma cells in the bone marrow. And this is what happened to them, the green line. They don't behave like 10% per year. They crash within few months. So to tell these patients that you don't have myeloma and let's watch you is basically asking for trouble. They're going to present to you with a cord compression, acute renal failure or something. If you saw them in January, this is going to happen in July. There's no point in waiting for these patients to have a problem, but rather go ahead and treat them. So that's the first biomarker we had. Just simply the number of clonal plasma cells is good enough. The second one is the free light chain ratio. The normal free light chain ratio, if you take involved over uninvolved, is less than 2. It's 1.65 or so. If you have a free light chain ratio of more than 8, the risk of progression to myeloma in a smoldering patient goes from 10% per year to 25% per year. But what if the ratio is more than 100? Then the risk of progression goes to 40% per year. So those are, again, patients you don't want to reassure, because in a high free light chain situation, the first myeloma defining event will be acute CAS nephropathy, which is what you don't want, because once they get CAS nephropathy, even if you can reverse it, the prognosis never becomes normal for those patients. So that was the second biomarker we used. And the third one was focal lesions on MRI. Even if you do a PET CT or a CT scan of the whole body, you will not pick up focal bone marrow lesions. You can pick up focal lesions in the cortical bone, but the MRI scan of the spine and pelvis is able to find focal bone marrow lesions that yet have not caused lytic changes. And so you can see those here. So if you have 2 or more focal lesions, you see that the risk of progression is much higher. It's a median time of just 1 year to progress. So it's 40% per year. So these 3 biomarkers, high bone marrow plasma cell percentage, more than 60, high free light chain ratio, more than 100, and 2 or more focal lesions on the MRI scan, identify a cohort of smolderers who are not going to be smoldering for years, but rather 80% of them will progress within 2 years. I will be happy to overtreat the remaining 20% because we are willing to save the 80% from end organ damage. This led to 130 of us working together, agreeing on the disease definition, and this paper was published in the Lancet Oncology in 2014. I was happy to lead this effort, and we redefined multiple myeloma. And again, the paradigm shift was not so much those 3 factors, but the willingness of 130 myeloma experts to say, we don't need to wait for end organ damage. We are willing to treat even without it. And so the new disease definition is I'm sorry. Okay, let's see here. I have to go back. The new disease definition is myeloma is defined as the presence or absence of myeloma defining events. There are 7 myeloma defining events that includes the usual crab features, renal failure, anemia, hypercalcemia, bone lesions attributable to plasma cell disorders, as well as these 3 biomarkers that I mentioned to you. Any 1 or more of myeloma defining events with 10% or more plasma cells in the marrow is myeloma. And then the other 2, smoldering definition, it's automatically altered when you alter the definition of myeloma. So smoldering becomes 10 to 60%, not just more than 10%, and MGUS stays MGUS. And instead of crab, no crab, we are saying myeloma defining events, yes or no. We also made one other important change in the disease definition paper, which is that we said we can look for bone lesions using CT scans and PET CT scans, and we don't need to rely only on skeletal surveys, which are not very sensitive. I do want to say that when you say smoldering multiple myeloma and you change the disease definition, people ask me, are all the studies with smoldering myeloma no longer valid because you're now calling a lot of the smoldering myeloma patients as having myeloma and starting therapy? Remember that the number of patients upstaged from smoldering to myeloma as a result of the new disease definition is very small, probably 10%. So 10% of smolderers are now being labeled as myeloma based on these new things. But that still leaves the vast majority of smolderers. They're still smolderers. And you can take these smoldering myeloma patients and really divide them into two groups. Those who have low-risk smoldering myeloma, where the risk of progression is quite low, probably 5% per year, and there's really no point in trying to do preventive trials. And then there is the group of high-risk smoldering myeloma patients who have a 25% per year risk of progression. How do we find out these high-risk patients? These are patients who are in Sagar's trial. These are patients who have high light chain ratios, more than 8 but less than 100. Patients who have cytogenetic abnormalities like deletion 17p or 414. Patients who have IgA type of smoldering myeloma. Patients who have circulating plasma cells. Patients who have very large M spikes, more than 3. Patients who have abnormal immunophenotype. So there are a bunch of disease of high-risk features. And this is published in Blood by Landgren, myself, and Marie Mateos on definition of high-risk smoldering myeloma, which you can look up. And that's the population that we need to do preventive trials. That's the population that's a target for randomized controlled trials. And there are two types of trials that are going on with that group of patients. One is trials designed to just see simply, can we prevent the progression of smoldering to myeloma, or can we delay the progression? The second type of trial is and can we prevent end organ damage? But the second type of trials that have been launched are that now that we are able to identify these patients, can we really cure smoldering myeloma? Can we cure multiple myeloma? People ask, why have we not cured myeloma? Well, number one, because we didn't have good treatments. Now we do have good treatments. But the bigger reason is we have not been able to cure myeloma because we've been calling myeloma as myeloma very late. It's like saying breast cancer is breast cancer only after you have lytic bone lesions. Then it is no longer curable. But if we redefine myeloma to start early and we're able to address this high-risk stage, it is possible that you can cure it. It's still a hypothesis. And based on that hypothesis, there are two cure trials that have been launched. The first one is called the CAESAR trial, which is going to treat high-risk smoldering myeloma patients with pretty much myeloma therapy and try to see if we can cure them. That trial has already finished accrual. It's in Spain. 100 patients were accrued within a few months because patients have a very important desire to participate in these kind of trials, which is, I don't want to just live 7-10 years. I want to just be done with it. I want to be cured. So the cure trial in Spain is already accrued. The same parallel trial in the United States is led by Shaji. It's called the ASCENT trial, and that trial is going to start accrual anytime soon. So I hope that we participate in it. I'm going to close with this. These are the implications of our understanding of the evolution of MGUS as well as the understanding of the evolution of the disease definition. Can we prevent progression? Can we prevent end organ damage? And most importantly, can we cure multiple myeloma? So thanks so much for having me, Sagar, and thanks to all of you for listening. Appreciate it. Thank you.
When you talk about racial disparities, of course, Africa is pretty heterogeneous.
Yes.
Is that true for all parts of Africa, West Africa, East Africa, North Africa?
Probably not.
No, Ghana.
No, probably not. And so it's hard to study that, though. In fact, we were thinking of doing a study where we study samples from different parts of Africa to see where it's coming from. That's hard to study. So we're doing a different study now. And I talked to Sagar, and hopefully we can collaborate on the team science with SPORE and things like that. One way we are looking at it is we know the origin of African Americans in the US. If we genotype them, we can precisely tell where in Africa the genes are coming from. And that's the study we are doing right now with genotyping race, not verbally reported race, but what is the real race based on where the origins are, not just for African Americans, but for whites as well. And so this study is being done right now at Mayo, where the race disparity is being studied based on not reported race, but real race.
And can I ask a follow-up? Are all those progression curves, are they the same for blacks and
Yes, it appears so. It's harder because we don't have a cohort of blacks that have been followed as rigorously. But Ola has done studies in the VA population and in the military population, and these have been published in Blood, where the prevalence of MGUS is higher in African Americans, but the risk of progression is identical to whites, 1% per year.
But on average, it presents 10 years earlier, but
And
almost
so,
identical to the prostate cancer data, where it's more prevalent in African Americans and younger age of presentation.
yeah,
And what's actually really interesting, they both have a predisposition for bone lesions.
yeah.
And I would argue that if the prostate folks had done what Bob did for MGUS, we wouldn't be treating all these patients for prostate cancer that have an MGUS-like prostate. They called it PGUS.
Hey, Craig, thanks so much.
I want to ask you to comment a little bit on something that's probably important both in Minnesota and Georgia, and that's the impact of obesity over time on MGUS. You touched on it a little bit, the risk factors, but that's an event in society that certainly has a linear trend along with your MGUS curves. And I was wondering if you could talk a little bit about what the relative contribution of obesity might be to MGUS, as well as some mechanisms of why obesity might be a causative factor.
I am not sure about the mechanisms, Craig, but I think it's really a concern because we've seen it in not just this one study, but in other studies as well. And it may not just be an increase in the risk of MGUS, but also a risk in transformation of MGUS to myeloma. So I think, and it's also important because it's a reversible thing. It is something that you can actually fix, unlike race or family history. So, and even pesticide exposure, because that occurred 15 years ago, 20 years ago. You can't do anything about it now. But obesity is a really, I think, a well-known risk factor now for MGUS and myeloma that can be addressed and can be fixed, and so it's important. If you look at the prevalence of myeloma or the cancer statistics published each year, how many new cases that we get? That used to be 11,000 new cases in 2000. It's 25,000 new cases each year in 2017. Part of it is the disease definition evolving. Part of it is, I think, aging of the population. But there's risk factors also changing. The racial mix of the population is changing. So it's important. I mean, this is no longer a very rare cancer. It's 25, 30, it's actually 30,000 in 2017. 30,000 new cases in 2017, almost tripling.
So, and if you look at, so Jay knows this from our GWAS study of 1,000 African Americans, one of the factors that fell out in just African is obesity again.
Yeah.
And it probably has to do with IL-6, because IL-6 is a pretty good, important survival factor for that transformed plasma cell, and IL-6 levels are higher
In obesity.
higher levels of obesity than so there probably is something related to the environment. Chris?
That's a very nice talk.
Thank you.
Sauter Sugar alluded to this in his comments. Have you thought about how this approach that you've used for MGUS applies to other cancers? So, for instance, CLL with follicular lymphoma, prostate cancer, or other cancers?
Absolutely. I mean, my studies with MGUS and myeloma have taught me disease definition is everything. I mean, I was on the phone with Kanti Rai, and we were talking about, had he called stage 0 CLL as, chronic lymphocytosis of undetermined significance, the prevalence of CLL will be different. How important CLL is felt will be different. Similarly, had Bob Kyle, instead of calling it MGUS, he just called it stage 0 myeloma, I mean, we would have had the most common cancer and all the grant funding you need. But just the terminology we use, we have to be really, really careful. I'm right now engaged in a big debate with some of my colleagues where some people want to call Waldenstrom's as any M spike of IgM, any level of bone marrow infiltration. That will make 1% of the United States have Waldenstrom's, but only 1,500 people really have Waldenstrom's in the whole country each year. So it's just making a disease definition change can have a big impact. That's one. And the second thing is, I think if you look at what they're calling B-cell lymphocytosis of undetermined significance now, or MGBS, or whatever, that's more or less similar to not just MGUS, but low-risk MGUS. Stage 0 CLL is similar to MGUS, the high-risk type. And stage 1 CLL is more like smoldering myeloma and myeloma. So I would like to do a paper at some point, and if people are interested in writing, let me know, where we match the progression probabilities and name or classify these diseases based on progression probabilities rather than on the way people initially named them 30, 40 years ago. Jonathan.
Again, thank you for the great talk as always. The challenge with trying to cure the population that we've chosen is that, as you showed, what we call smoldering myeloma is probably not smoldering myeloma, it's probably not myeloma. And so just like we have a challenge curing myeloma now, we probably are not going to be able to cure them even if we're looking for drug induction, double transplant. And the people we could potentially cure are half of the patients that we're not trying to cure.
Yeah, I mean, absolutely. And this is why it's both fascinating and challenging at the same time. I would like to think like one way of looking at it is this is a type of cancer that you can never cure. It's like CML, I'll just control it and people live for a long time. As long as I keep them from having end organ damage, it's okay. The other way to look at it is to say that, no, it's possible that it's curable. And 5 years from now, we may think, hey, you know what, all those years we didn't try to cure myeloma, it was just because we were treating too late. Is that possible? It could be like a black swan thing. In retrospect, it looks, oh yeah, it's so apparent, but then prospectively, it looks like it's a bad thing to do. I don't know which of the two is correct, but we want to, that's why, explore both paths. So at the same time, I'm working with Janssen on a daratumumab versus observation smoldering trial, which I'm probably knee-deep in. I'm also doing the ASCENT trial, which is trying to cure smoldering myeloma, and I don't sense a conflict there for me because I feel like I don't know which approach is going to be right in the long run, but I would rather do both. I'm testing both approaches. One is just simply try to prevent progression or delay progression, and the second is try to go all out. And you're saying, well, the low-risk smoldering might be the only people who can be cured, but the price is too high to pay there, you know, trying to give chemotherapy to those people.
Thank you for such a great talk. So your point is extremely well made about the importance of these population-based studies, and I congratulate how this has been done over such a long period of time, but the ability to fund such a population-based study is near impossible at this point, and it seems like the data you're collecting would not be available, for example, from a tumor registry or something like that. So how has Dr. Kyle and others been able to fund and sustain this very long longitudinal population-based study?
Yeah, you're absolutely right. Trying to fund these brand new is becoming difficult. We are able to do it again because of, you know, Bob had a program project grant for about 15 years. So in those years, the NCI was funding just simply, I mean, if you write a study saying, I just want to study all of Olmsted County and figure out how many people have MGUS, nobody's willing to give money. But those years, they did. And that allowed us to establish it. And we've subsequently kept some population-based funding alive, but a lot of it is Mayo funding. I mean, internal in-house funding, where when your grant goes out, it's really on biomarkers and things like that. But internal funds that you get to sustain your own efforts, you pull into that. For example, I've given almost all my research funding just to the statisticians. Just help me do the biostats on this, because it's not something that, or the core facilities which nobody's willing to give money to fund. Tom?
Thanks again. Just kind of come back to what you and Jonathan were just talking about. And Bob, a few years ago, once said that if we all live to be 200, we'd all develop myeloma.
Pardon?
Bob,
If we live to be 200.
So, do we just not have anything that we can, if the precursor disease is MGUS, we just don't have anything good enough to treat MGUS with?
Probably not at this point, because, you know, it is not possible. If it's an isolated colon polyp, you can remove it. If you have a colon cancer that's coming from familial colon polyposis, you have to remove the whole colon. If it's MGUS, that's the same problem we have. It's just that there are too few of these cells. Trying to target them is going to require some type of intervention. So unless we find the precise BCR-ABL-like translocation that specifically causes MGUS to progress. And that's challenging because what we call MGUS and myeloma, I was talking to Vivek about this yesterday, is not one disease. There is a trisomic MGUS which has a certain reason why it happens and a certain reason why it progresses, which is quite different from 11-14 MGUS. We are calling it myeloma, but it's actually like calling lymphoma as lymphoma. I mean, there's so many types But because we are dealing with a rare disease, we've just collectively called it myeloma and trying to find out. I think if you want to find out why MGUS becomes myeloma, you have to stop calling MGUS to myeloma, but rather say, why does T1114 MGUS become T1114 myeloma? That's where the solution is. It's going to be different than why a 414 MGUS becomes a 414 myeloma. And what's the driver is going to be different, how you intervene is going to be different. And so then it becomes complicated because these are smaller and smaller patient populations.
Again, a fantastic talk. So I'd like to ask you, as a non-myeloma expert, so if you go
He
to
is a non-myeloma.
progression from early stage smoldering and eventually myeloma, then how much do we understand the genetic alteration each steps? I think, of course, we have a lot of TCGA or some out there that is available, but those steps of understanding are probably helping for the stop the progression.
Yeah, we are understanding some amount. I'm fairly dogmatic, but maybe it is not true, but my understanding is that plasma cells are dividing primarily in response to infection. And so when the first infection or the first stimulus happens, when they are dividing, they're trying to do a class switch, right? When you first get an infection, you get IgM producing cells. When you get the same infection the second time, IgM becomes an IgG. There is a class switching in the heavy chain locus that takes place. When the class switching happens, there is an error, and that causes an IgH translocation. And so with these immunoglobulin heavy chain translocations in myeloma, the 1114s, the 414s, they're occurring at the class switch region. And so it tells me that there's some stimulus that's causing the myeloma cells to divide. There's a class switch. When the class switch is happening, there's a translocation that occurs. And when the translocation occurs, now you have a driver mutation that sustains the clone, and you get establishment of MGUS. So if you have populations like in Africa where there's a higher risk of infection, they have a higher risk of polyclonal hypergammaglobulinemia and a higher risk of MGUS because they've been exposed more often to the same thing, and there's a higher probability that one time they're going to get MGUS. The second transition, and this is something that Leif Bergsagel's theory from mouse model studies, is that there is a MYC pathway by which an MGUS becomes myeloma, and then there's a RAS mutation pathway by which MGUS becomes myeloma. He thinks that one of those two addresses almost all progression. MYC mainly in the trisomic myelomas, and RAS mainly in the translocated myelomas.
Jay gets the last question. I'll take it. Go ahead.
Thanks, Vincent.
Hey.
Mike, if I take the analogy of the staging system from the past in myeloma, so clearly you have shown that the prognosis in ISS and setbacks have shown superior to what you have shown, which is predominantly a reflection of tumor growth. So take the same analogy to myeloma, the risk stratification that you put out, which is data for clearly in one molecule saying that you get, say, free light chain abnormality of the bone marrow plasma cells. It's not a reflection of tumor burden. It's more of a consequence of it, of something else. But it's not, it probably, there should be some of the biological features that has to come into this stratification.
Oh, yeah, absolutely. Yeah, go ahead.
Can you comment on how to further stratify using more of the biological factors in the staging system?
Yeah.
From a myeloma perspective?
You're talking about the Smoldering classifications, right? Yeah, so part of the problem has been, and people have done this, where you take, even if you do single cell analysis, the MGUS and myeloma look virtually identical. So it has been very difficult to look at a cell, whether morphologically or cytogenetically or by even gene sequencing, to say, is this MGUS or myeloma? So right now, for the moment, we are relying on just very crude parameters like, percent of plasma cells and free light chain ratio, which are really markers of something else, mainly because we are not able to find the single genetic difference that separates MGUS from myeloma. But it is there. It's got to be there. There's got to be something that is totally different between MGUS and myeloma. It's just we haven't found it. So we are still pursuing it. And I think part of the reason why we may not have found it so far to just look at biology and say which is MGUS, which is myeloma, is that we've been lumping different diseases together and trying to separate the two. If we focus on just each one of the 1114s and 414s as unique diseases, we may be able to find what's different.
And it may have to do with the immune microenvironment.
It could be.
Look at Mayo's model where he can take patients that are MRD negative. You take a sample from their marrow, put it in his mouse model, all of a sudden now the clone starts to grow again.
Yeah.
So where the immune microenvironment is different, that may be.
Yeah, exactly.
For those of you, I know there are other questions. You can come up. Vincent's going to be here to meet with the fellows afterwards. Thank you again, everybody.
Thanks so much, guys.